Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
I am Dr. Adesanya, a family medicine physician scientist and assistant professor in the Department of Family and Community Medicine at The Ohio State University, and a member of Cardi-OH's Team Best Practices. In this podcast, we will discuss lipid management and treatments, going beyond statin therapy, and how to practically select and prescribe non-statin therapies. With me today is Dr. Wesley Milks, an associate professor in the Division of Cardiovascular Medicine at The Ohio State University. Dr. Milks is both a cardiologist and a clinical lipidologist and serves as the medical director of cardiac rehabilitation at the Ross Heart Hospital. Dr. Milks, thank you so much for being here.
Thank you for having me here today. It's really my honor.
You're very welcome. So, as mentioned in your introduction, you are a clinical lipidologist. That's a special area of focus that our listeners may not know much about. Can you please tell us what types of patients you see and the expertise that you share with them?
Of course, our specialized clinical team cares for patients with established cardiovascular disease or elevated risk of developing a first atherosclerotic cardiovascular disease event. We focus on those who may have complicating factors such as intolerance to or difficulty achieving goals with standard therapies, a strong family history of premature heart disease, severely elevated triglyceride levels, metabolic syndrome, familial hypercholesterolemia, or those who are at elevated risk for lipid-related medication interactions, like those who have had a solid organ transplant.
Wow, that's an amazing breadth of important services, all critical for the prevention of cardiovascular disease. What lipid measurements would you say are the most important for initial assessments of cardiovascular risk?
Historically, most population guidelines have focused on low-density lipoprotein, or LDL cholesterol, which most people know as their bad cholesterol, because it makes up about 75% of atherogenic or plaque-depositing cholesterol. LDL is important, and from multiple studies we know that the lower, the better. And there does not appear to be a too low level that can be achieved by treatment. If you can reduce an individual's LDL by 40 milligrams per deciliter, you can drop their 5-year atherosclerotic cardiovascular disease, or ASCVD, risk by 20%. So we might refer to that as the 40-20 rule. With this said, LDL is really just part of the picture for most patients. There are other types of lipoproteins that deposit cholesterol as well. So we like to focus on the non-high-density lipoprotein, or non-HDL value, or ideally even the apolipoprotein B, which is ApoB value, more so than the LDL, especially when the triglycerides are elevated. In those cases, a greater amount of cholesterol is carried in triglyceride-rich lipoproteins like very low-density lipoprotein, VLDL, or chylomicron remnants. The ApoB value can reflect a summative burden from all potentially atherogenic lipoprotein particles. And when ApoB is not available, non-HDL is useful because it's widely available and it's easy to calculate just from a standard lipid profile.
Okay, so non-HDL. I don't often look at that value first. Can you remind our listeners what that encompasses and why it is important?
So when LDL and non-HDL values are discordant, meaning that one of those metrics is at goal, but the other one is still elevated, the non-HDL value actually correlates more strongly with the ASCVD risk level. Some laboratories will report the non-HDL value specifically, but if you want to calculate it yourself, you just subtract the HDL from the total cholesterol concentration. So we really want to also take a look and not ignore that non-HDL value, again, particularly in patients with diabetes or high triglycerides, in whom a much greater burden of cholesterol tends to be carried in those non-LDL, non-HDL, or so-called remnant lipoproteins that tend to be triglyceride-rich.
Got it. And then what are the goal LDL and non-HDL thresholds used for treatment?
In primary ASCVD prevention, for people with a 10-year ASCVD risk estimate less than 20%, the goal LDL of less than 100 milligrams per deciliter and non-HDL value of less than 130 milligrams per deciliter is reasonable. For people considered high risk, and that is people with a 10-year ASCVD risk estimate greater than or equal to 20%, people being treated for secondary prevention, so if they've already had a heart attack or stroke or another arterial problem, or people with a baseline LDL of greater than or equal to 190, many of whom will have a genetic cause of familial hypercholesterolemia, the goal of LDL of less than 70 and non-HDL less than 100 might be more appropriate. So as you see, the non-HDL threshold is often considered 30 points higher than the LDL threshold. Many people, however, are considered very high risk, i.e., those people who have had multiple ASCVD events or who have had one ASCVD event with multiple other high-risk conditions. For these individuals, the goal LDL should be less than 55 and non-HDL should be less than 85.
Thank you for outlining those thresholds. What are examples of high-risk conditions?
High-risk conditions might include current smoking, hypertension, diabetes, chronic kidney disease, inflammatory diseases, because we know chronic inflammation can drive atherosclerosis, or age 65 years or greater. Now, in the primary prevention group, again, in people who have not already had an established ASCVD event, it's also really useful to look at CT imaging or other imaging biomarkers to see if subclinical atherosclerosis is present. You might also consider a dedicated coronary artery calcium scan if the patient's not already had any imaging of the chest for other reasons, such as for evaluation for a pulmonary embolism or screening for lung cancer, for example. These are all things that should guide clinical risk discussions with patients. And I will say that patients can be really motivated by seeing the images of their own heart. They can see those white areas of plaque and really recognize that that atherosclerosis process is there in them and really shouldn't be there. And so it can be a very motivating factor for them to get on top of their cholesterol-lowering therapy.
I can only imagine. Thank you so much for that very practical pearl. I really appreciate that. This information is also high yield and with quite a few numbers. I'll take a second to review them for our listeners. Let me see if I have this right. For secondary prevention, individuals who are at high risk, which turns out to be a large proportion of people, the goal LDL is under 55. Otherwise, the goal LDL is under 70 for secondary prevention. For primary prevention, if someone's 10-year risk is over 20% or their LDL at baseline is over 190, the goal LDL is under 70. And for everyone else, the LDL goal is under 100 for primary prevention. The general rule is to add 30 to these numbers to identify the non-HDL goal. Did I get it?
That's right. Understanding these thresholds is a great start.
Thank you. I'd like to talk more about this LDL goal of less than 55. So a lot of people should really have a goal LDL of less than 55, it seems. Can you tell us a bit more about the evidence base for this?
Yes, many patients should be headed towards that lower goal of LDL less than 55, more than many clinicians might realize. Remember, these are patients who have either had multiple ASCVD events or have had one event with multiple high-risk conditions. This comes from the expert consensus statement endorsed by the American College of Cardiology, or ACC. There is a summary of evidence from a number of clinical trials that individuals who achieve LDL less than 55 experience lower event rates than those with higher LDL. It's worth noting also that this ACC expert consensus statement has lagged behind some of the guidance from the European societies. Prospective and observational trials demonstrate a direct and significant relationship between LDL level and atherosclerosis progression and ASCVD event risk, and the absolute LDL reduction is directly associated with ASCVD risk reduction. It's really remarkable to see the figure of those placebo groups and treatment groups of the statin trials over the years, such as from the cholesterol treatment trialist collaboration, that demonstrates that very linear relationship between LDL level and ASCVD risk level. And by the way, there appears to be no lower LDL level below which benefit ceases.
I see. And then how much should we expect statin medications to lower LDL levels?
So low intensity statins will lower LDL up to about 30%. Moderate intensity statins will lower that LDL by about 30 to 50%. And then high intensity statins, so we're talking about atorvastatin, 40 to 80 milligrams, or rosuvastatin, 20 to 40 milligrams, can lower that LDL by about 50% or more, assuming that the patient is adherent to therapy. Sometimes, even if patients are meeting LDL goals, they could benefit from being titrated to a higher intensity statin for their pleiotropic vascular effects. And we talk about that concept, particularly in the secondary prevention population.
So we've discussed the importance of addressing and lowering cholesterol, but as a primary care provider, I often see people who do not tolerate attempts to try multiple different statins, or their LDL is improved on maximal statin therapy, but not to goal. Beyond high intensity statins, how do you get to goal LDL levels for these patients?
So, this is an important and unfortunately common clinical scenario. Many people just don't get to their LDL goal on high intensity or maximally tolerated statin therapy. We know that a lot of patients are unable to take any statins whatsoever. So, fortunately, in 2025, we have multiple useful non statin options.
Can you tell us more about these?
Yeah, the first non statin option that guidelines suggest, and which I do use very commonly in my own practice, is ezetimibe. That has the trade name Zetia, although fortunately it's widely available and inexpensive as a generic formulation. Ezetimibe is an oral medication that works by reducing the intestinal absorption of cholesterol. So on its own, ezetimibe will decrease LDL values by about 15 to 20%, but when you add ezetimibe to a statin, the ezetimibe can synergistically produce closer to a 20 to 25% LDL lowering. Often, if a patient is adherent to atorvastatin 40 milligrams daily, for example, and still needs significant LDL reduction, adding ezetimibe promotes much more incremental LDL lowering, again about 25%, as compared to doubling the dose of that already high-intensity statin, which would only get you another 5 to 10% LDL reduction. Ezetimibe is sometimes associated with rhinorrhea, but generally is among the best tolerated of the lipid-lowering medications that I use. It's largely metabolized in the intestinal wall, thus resulting in less systemic absorption, so we might think it produces less systemic side effects for that reason. Even patients with statin intolerance tend to tolerate ezetimibe very well.
Has ezetimibe been shown to decrease cardiovascular death?
Yes, so the Improve It study was published in the New England Journal of Medicine in 2015. This was a large trial involving more than 18,000 patients. So to give you a comparison, that's about the seating capacity of Madison Square Garden. In this trial, patients were randomized after a diagnosis of acute coronary syndrome to take either simvastatin alone or simvastatin with ezetimibe. LDL decreased from 70 in the control group to 54 when ezetimibe was added. In addition to the cholesterol levels clearly decreasing, the event rate of cardiovascular death, non-fatal MI, unstable angina requiring hospitalization, and coronary revascularization or non-fatal stroke, so that kind of composite cardiovascular disease endpoint, at 7 years was 32.7% in the combination treatment group, that included ezetimibe, compared to 34.7% in the control group. So while that's not a large observed difference in absolute terms, this was statistically significant and was really considered groundbreaking as one of the first non-statin agents to show a demonstrated cardiovascular disease outcome improvement.
Got it. So these results are with ezetimibe and a statin. Is there any data evaluating ezetimibe by itself?
Yes, there is a study from Japan that was released in 2019. It was an open label trial in patients over 75 years of age. They had an LDL value of over 140 at baseline and known atherosclerotic disease risk factors or peripheral artery disease or stroke, but without established atherosclerotic heart disease. LDL decreased from an average of 162 to 131 in the control group and 120 in the study group. The hazard ratio of CVD endpoints of 0.66 was quite impressive, although there was no statistically significant decrease in all-cause mortality in this trial. There were some positives and negatives to this study, including a higher than average event rate and ultimately a 20% dropout or loss to follow-up rate. The authors also excluded patients with prior MI or coronary revascularization. So that does limit the generalizability perhaps a little bit. Still, to me, this makes ezetimibe monotherapy a very reasonable and data-supported option in a high-risk older population who can't tolerate statins.
It really does. And this really excites me to consider the use of ezetimibe more as a solo agent in people who are intolerant to statins. PCSK9 inhibitors, proprotein convertase, subtilissin, kexin type 9 inhibitors are the other popular class of medications that I hear a lot about for hyperlipidemia. Can you tell me a little about them?
Yeah, absolutely. So the way PCSK9 inhibitors work, you've got your LDL receptors. They might be sitting on hepatocyte cells. They bind LDL and remove LDL from circulation. So PCSK9, the protein itself, is an enzyme that targets these LDL receptors and shuttles them in the cell for breakdown. So if you inhibit the PCSK9 enzyme, you avoid the breakdown of LDL receptors, leading to increased numbers of available LDL receptors to help remove the LDL from the circulation. So basically, you're recycling the LDL receptor more and getting more LDL out of the bloodstream. PCSK9 inhibitors are monoclonal antibodies that result in profound reductions in LDL, about 60% additional LDL reduction in patients who are already treated with a statin. There are two commercially available formulations that are available for patients to inject at home, usually every 2 weeks: evolocumab under the trade name Repatha and alirocumab with the trade name Praluent.
And do they have cardiovascular outcome data?
Yes, they do, and robust data at that. The two largest studies for each of the monoclonal antibody PCSK9 inhibitors were done in patients who are already taking statins. We're talking about the Fourier study for the evolocumab and the Odyssey outcomes study for alirocumab. They both showed reductions in composite cardiovascular events on the order of a hazard ratio of 0.85 over a follow-up median time point of just 2 to 3 years.
And we have a table that we will link to for sure in the show notes. We often hear about inclisiran. What is it and how is it different from monoclonal antibody PCSK9 inhibitors?
Yes, inclisiran is a really exciting and interesting therapy. It's sold under the name Leqvio. It's a small interfering RNA that helps degrade PCSK9 mRNA. So you're leading to less PCSK9 protein being produced because you're inhibiting really the transcription of that. Inclisiran is administered as a subcutaneous injection at a medical center or infusion clinic with a baseline injection, a second dose at 3 months, and then the long-term dosing interval is just once every 6 months afterwards. In the Orion trials, adding inclisiran to maximally tolerated statin therapy resulted in about a 50% reduction in LDL cholesterol, so quite significant. We don't have the full adjudicated outcomes data yet, although some early data is arriving and looks promising. We expect those trials to be fully finalized in a couple of years. But with those degree of LDL reductions, we are very likely to observe associated ASCVD risk reduction with inclisiran therapy as well. Inclisiran is an excellent option for those patients who prefer less frequent dosing intervals of medications, so like those patients who travel a lot, for example, or those who don't tolerate monoclonal antibody PCSK9 inhibitors because of side effects or difficulty using the pen injectors at home. Inclisiran received FDA approval in December of 2021 for use in conjunction with dietary modification and maximally tolerated statin use.
Very exciting. And you started to talk about this, but with multiple different options, how do you choose which PCSK9 inhibitor to use?
So we usually start with one of the monoclonal antibodies that can be done at home. Most insurance plans have a formulary preference, and I use and trust both of them. Again, that's the evolocumab or Repatha and alirocumab, which is Praluent. We might think of use of inclisiran when someone can't use those pen injectors at home, if they have a fear of needles, or really just uncomfortable doing those self-injections. Other patients might appreciate the ease of that long dosing interval between the inclisiran shots, which again, for long-term therapy is just once every 6 months. For some people whose insurance will not cover a monoclonal antibody PCSK9 inhibitor very well, inclisiran can actually be processed through their medical rather than prescription insurance coverage more easily since it's done at a healthcare facility and not at home.
Are PCSK9 inhibitors generally well tolerated?
Yes, they are. Some people may have a little soreness or skin reaction at the injection site, but it's uncommon that this reaction would limit therapy. Some patients will report a bit of a runny nose, a mild cough, or just kind of feel like they're coming down with something for a day or two after the injection, like you might feel after a flu shot. But even that is not very common or limiting of the therapy.
And do you have any PCSK9 prescribing pearls?
Yes, it might seem intimidating at first, but prescribing of PCSK9 inhibitors is fairly straightforward. Prior authorizations are often needed, but if patients have tried the other medications and meet the documented criteria, PCSK9 inhibitors are straightforward to get covered by insurance with proper documentation. Ohio Medicaid does require a PA for PCSK9 inhibitors and requires a failure of statin and/or ezetimibe prior to approval. Most patients do have copays with PCSK9 monoclonal antibody inhibitors, and there are assistance programs and grants from the associations like HealthWell and the Patient Access Network that can also help to offset some of the copays. The monoclonal antibody PCSK9 inhibitors can be more expensive for patients with Medicare, which is why we'll sometimes consider inclisiran if other options are cost prohibitive for patients in this population. Even with Medicare, however, as I've come to learn recently, there's now an out-of-pocket cost cap of $2,000 per year, and there are updated plans called smoothing plans, which sort of smooth out the costs over a 12-month period to help patients reach their yearly deductibles in a more gradual manner. Good documentation generally garners approval for both of these agents, and indeed, the inclisiran running through medical benefits rather than drug benefits can be cost favorable for many people.
Didn't the FDA recently approve another medication for use with or without statins?
Yes, so you're referring to bempedoic acid. That's another oral medication. Bempedoic acid was FDA approved in 2020 as an adjunct to diet and maximally tolerated statin therapy. It was also approved as a combination tablet with ezetimibe, which is called Nexlizet, in 2020. And then in March of 2024, bempedoic acid received approval as monotherapy for patients with statin intolerance in a primary prevention group. Bempedoic acid is approved for both primary and secondary prevention, so we consider using it in those patients who might have very high cardiovascular risk if they've not had success with statins and ezetimibe, or for whatever reason they cannot take PCSK9 inhibitors.
I see. How does bempedoic acid work?
Bempedoic acid, which is under the trade name Nexletol, inhibits cholesterol biosynthesis, but it does this upstream of where statins work. So we know statins work at the rate-limiting HMG-CoA reductase step. Bempedoic acid works at the ATP citrate lyase step, which is upstream. Bempedoic acid is a prodrug. It's activated in the liver, so maybe for this reason we don't tend to see as many muscle-related side effects with it. It is, however, much less effective at LDL lowering than statins, only about 20% when used as monotherapy, although significantly more when used in combination with ezetimibe. In the CLEAR Outcomes trial, including almost 14,000 participants, bempedoic acid, compared to placebo in patients with statin intolerance, was associated with a lower risk of major cardiovascular events, but not mortality over the course of a 40-month follow-up interval.
And are there any risks or side effects associated with bempedoic acid?
Bempedoic acid does increase uric acid levels, so we have to ask patients if they have a history of gout or hyperuricemia. We might want to avoid bempedoic acid in those people, or at least be careful with it in combination with other agents that could increase the uric acid level, like thiazide. Uric acid needs to be checked at baseline after initiation of bempedoic acid, and then on therapy as well. Bempedoic acid, interestingly, also carries a rare risk of tendon rupture, so we want to evaluate any history of tendinopathies or tendon rupture before starting it, and perhaps advise patients to avoid medications with similar risks like fluoroquinolones. Other risks include serum creatinine elevation or muscle spasms, and those are documented, although I can't say as I've seen that one.
Wow. So it appears we have quite a few new options for cholesterol management. How do you integrate these with statins in the older medications like bile acid sequestrants, fenofibrates, and niacin?
Yeah, those agents that you mentioned have been around for a long time and are falling out of favor, but do occasionally still have their role in patients, especially who have tried a lot of the first-line agents and can't get a good result with their treatment. So bile acid sequestrants work like dietary fiber in the sense that bile acids are bound in the GI tract to be excreted rather than recycled and reabsorbed. This leads to increased biosynthesis of bile acids, a process that uses up cholesterol and thus lowers LDL levels in that way. Typical LDL reduction with bile acid sequestrants is about 15 to 20%. However, about 6 pills a day are frequently needed to get the maximal effect, which is associated with a frequent GI intolerance. Bile acid sequestrants can increase triglyceride levels, so we try to avoid them in people with hypertriglyceridemia, but they can help lower blood sugar levels a bit. There are also plant sterol and stanol supplements, compounds that are found naturally in fruits and vegetables that compete for absorption with cholesterol. 2 grams per day of phytosterols have been shown to lower LDL levels by about 5 to 10%, but the average American diet comprises of only about 250 to 500 milligrams daily, which is well below the amount needed to lower LDL significantly. Of course, there are many other reasons to tell patients to increase their fruit and vegetable intake, but beyond just the natural sources of these phytosterols, there are supplements that people can take either in capsule form or in butter-like spreads, and these are particularly useful in people who just want to avoid prescription lipid-lowering therapy at all costs. Fenofibrate and niacin treatments are not typically used in the context of ASCVD risk reduction currently because they don't have proven benefit as statin add-on therapies or alternatives, and they can have significant side effect profiles as well. I will note there is a role for fibrates in triglyceride lowering in individuals with severe hypertriglyceridemia, but even then, we prefer to use other therapies like diet and exercise, omega-3 polyunsaturated fatty acid medications, and statin therapy when indicated. We need to monitor renal function for patients on fenofibrate and dose the medication accordingly if there is renal function impairment.
Thank you so much. That was a wonderful and much appreciated review of a lot of the older medications. With regards to the newer medications, how do you integrate these into your clinical practice?
That's an excellent question, and it gets to the both science and art of medicine, I would say. Of course, it comes down to the clinical need, the specific patient, and the degree of LDL reduction that's necessary. I will start with the clinical scenario that's pretty common in my practice of a patient who has established ASCVD and is on maximally tolerated dose of a statin. Their LDL is still not at goal. So given the straightforwardness of oral therapies and also in alignment with insurance requirements, I will typically start with adding ezetimibe to a statin. We recheck lipid levels in at least 6 to 12 weeks after a dose adjustment or new agent, and if still not at goal, we'll add in a monoclonal antibody PCSK9 inhibitor. If the patient is then below their goal, I will either keep the patient on all three or allow the patient to stop the ezetimibe given the much lesser effect in comparison with the PCSK9 inhibitor. If the patient doesn't tolerate the monoclonal antibody PCSK9 inhibitors or has a strong preference for longer dosing intervals, then inclisiran is a really good choice for them. However, as we mentioned before, inclisiran is given at an infusion center rather than at home, so that may not be preferred for many people.
Yeah, I was thinking an infusion center could be a big decision that could have some barriers for patients, such as access, costs, and travel to a big city health center. I'd envision you would need to have some detailed conversations with patients about this. What kind of conversations are you having with your patients about which to start, and how do you involve them in these conversations? Is there some shared decision making?
Definitely a lot of shared decision making needs to happen with lipid lowering therapy, particularly in patients who have had trouble with certain lipid lowering medications. A lot of the shared decision-making considerations are detailed in Table 4 of the ACC statement. There are several categories that are important to consider, not only including the anticipated LDL reduction for any given agent, again, assuming a good adherence, and also the risks of adverse effects and costs. So we talked about the use of generic medications, which are widely available, versus other newer medications, which still will carry a big price tag to them. There are also patient preferences, like we talked about, whether certain patients might be comfortable with an autoinjector pen versus really wanting to avoid needles.
And we can link to that table in the show notes as well. While thinking about patient considerations and larger populations, can you tell us about representation and disparities in the trials of these medicines?
That's a great point. Black and Hispanic populations and women, particularly of childbearing age, have been significantly underrepresented in many cholesterol treatment trials. There have been disparities in cholesterol treatment prescribing rates that maybe follow that. The Fourier trial we discussed earlier on the PCSK9 monoclonal antibody inhibitors had a 4% Black participants, for example. Notwithstanding, the cardiovascular benefit of many cholesterol treatments has been demonstrated across diverse populations, even despite underrepresentation in clinical trials. So ongoing efforts really should prioritize recruitment and retention of trial participants from diverse backgrounds and mitigation of factors that could contribute to prescription disparities as well.
A very important point. And then a final set of focused clinical questions. How does your treatment approach change for the patient who just cannot tolerate a statin? Would you consider starting 2 agents at once for a patient with a true statin intolerance?
I think you're right that many patients do need to be on multiple agents to achieve their goal. However, I'm hesitant to start multiple agents simultaneously, probably because patients who make it to my office have often had bad experiences with cholesterol-lowering medications, especially statins. So I don't start 2 medications simultaneously, but often sequentially. Ezetimibe is almost always the best next step after maximally tolerated statin therapy. Ezetimibe is available as a generic, so its cash price is less than $10 for a 90-day supply on cost-plus drugs, for example, and thus it's really cost-effective. Due to limited LDL reduction of about 20% and higher side effect profile, bempedoic acid is typically reserved mainly as primary prevention and can be limited by its persistently high cost. Importantly, however, all of these non-statin therapies are available and can be added in even while titrating and adjusting statin dosing to determine the true maximally tolerated lipid-lowering regimen for each individual patient.
Wow. Dr. Milks, this has been very, very informative today. We've covered so much breadth and depth. If you had to give a lipidologist most important advice to primary care providers on cholesterol management, what would you want us to take home from today's discussion?
First, I would just say get the patient's LDL, or better yet, their non-HDL and ApoB as well, to goal. Take the time to set and discuss these goals with patients and work together to achieve them. We can save lives and hearts if we do this. Secondly, we have several more tools in our tool bags than we did 5 years ago, so please use them.
That seems like excellent advice that I will certainly take back to my clinic. Thank you so much for taking the time to talk with me and the cardio community today, Dr. Milks. Together, I think we can save lives and hearts with state-of-the-art lipid management.
Thank you so much for having me. It's really been a privilege.
You're welcome. And a special thank you to you, our listeners, for tuning into Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.